The patient is sitting or standing. The patient's arm is passively elevated through forward flexion by the examiner, forcing the greater tubercle of the humerus against the acromion. A positive sign is reproduction of the patient's pain symptoms in their shoulder. The patient is sitting or standing. The examiner forward flexes the patient's arm to 90 degrees, then the examiner passively internally rotates the shoulder. This forces the supraspinatus tendon against the coracoacromial ligament. A positive sign is reproduction of the patient's pain symptoms in the shoulder. The patient is standing or sitting and performs active abduction 3 to 5 times while the examiner records the location of the onset of the painful arc range. The patient is then asked to give a subjective indication of the amount of pain. The test is then repeated while the examiner applies a gentle inferior or posterior inferior glide just prior to the onset of the recorded painful arc. The patient is then asked again to give a subjective indication of the amount of pain. The test may also be modified such that the patient is in a supine position. The patient is supine with their shoulder in 90 degrees abduction and elbow in 90 degrees flexion. The examiner stabilizes the patient's elbow with one hand and applies an external rotation force with her opposite hand to maximum shoulder external rotation. A positive sign is reproduction of the patient's throwing pain symptoms. The patient normally complains of pain deep within the posterior aspect of the involved shoulder. The patient may be sitting, standing, or supine. The examiner places the patient's shoulder in abduction and external rotation. The examiner then applies an external rotation force. With a positive sign, the patient has a look of alarm or apprehension on their face due to a feeling of instability and resists further motion. The patient may also have pain with this maneuver. The patient is supine. The same procedure is performed as the apprehension test with the patient in a supine position. Upon finding a positive anterior apprehension test, the examiner maintains that position and applies a posterior force to the patient's humeral head with one hand to the patient's proximal humerus. With a positive sign, the patient's alarm or apprehension disappears. Their pain is relieved, and the examiner can take the patient's shoulder into further external rotation without apprehension or pain. The patient is standing or sitting. The patient should be relaxed with their arm by their side. The examiner grasps the patient's forearms below the elbows and pulls distally or inferiorly. With a positive sign, a sulcus or gap appears at the glenohumeral joint. Remember to compare this to the patient's uninvolved shoulder, as many individuals have some degree of natural laxity. The patient is supine. The examiner grasps the patient's proximal forearm with one hand and flexes their elbow approximately 120 degrees. Then the examiner positions the patient's shoulder in varying degrees of flexion. With the other hand, the examiner stabilizes the patient's scapula. The examiner attempts to sublux the humeral head posteriorly by applying an axial load through the humerus, forcing the humeral head posteriorly. With a positive sign, there is greater posterior displacement or subluxation compared to the uninvolved shoulder and possibly apprehension by the patient. The patient is supine. The examiner grasps the patient's proximal humerus with one hand and proximal forearm, elbow, or distal humerus near the elbow and positions the patient's shoulder in approximately 20 degrees of abduction and flexion. The examiner then loads the patient's humeral head such that it is centrally located in the glenoid fossa. The examiner then applies anterior and posterior forces. With a positive sign, there is excessive displacement either anteriorly, posteriorly, or both when compared to the uninvolved shoulder. This test consists of 2 maneuvers. During the first maneuver, the examiner stands behind the patient and stabilizes their opposite shoulder and trunk with one hand. Then the examiner uses their hand closest to the test shoulder to apply forces through the patient's extended forearm while the patient is sitting with their shoulder flexed to 90 degrees, adducted 10 to 15 degrees, maximally internally rotated, elbow fully extended, and with their forearm maximally pronated. The patient resists as the examiner applies a uniform downward force to the upper extremity at the proximal forearm. During the second maneuver, the patient maintains the same initial position as described with the first maneuver, except the patient then maximally supinates the forearm and externally rotates the shoulder, and again resists the examiner's downward force on the upper extremity. With a positive sign, the shoulder pain is reproduced with the first maneuver and reduced or eliminated with the second maneuver. Pain at the acromioclavicular joint suggests acromioclavicular joint pathology, while pain and/or clicking described inside the glenohumeral joint itself suggests a labral tear.